This is the second tutorial on the basics of hyponatremia. This time we're going to look at a couple of clinical scenarios on hyponatremia, how you work through the problems and how you treat the patients. Hyponatremia, Part 2, Working the Problem. Welcome back. In the previous tutorial I discussed hyponatremia and its physiology and how it presents. We then discussed the different types of hyponatremia: hypotonic, isotonic, and hypertonic. I subsequently discussed the diagnostic pathway for investigating hyponatremia. In this tutorial, I'm going to look at some common clinical scenarios of hyponatremia, working the hyponatremic problem, and the treatment of acute hyponatremia. Let's start with a clinical scenario. Matthew arrived in the ED with mild flu-like symptoms and his plasma sodium is 120 millimoles per litre. What treatment should Matthew get? Before we get into a discussion about treatment, it is important to remember that Matthew is asymptomatic and you have time to think about what to do. But this level of dysnatremia is not good. Small shifts in serum osmolality may cause disruption of brain mass. It is important to remember that hyponatremia is indicative of extracellular osmolality, but it may also occur in the setting of different body volume status. The patient may be normovolemic, hypovolemic, or hypervolemic, and these need to be assessed. If Matthew is hypovolemic, one needs to administer sodium and volume. If he is normovolemic, he needs sodium. And if he is hypervolemic, total body sodium may be normal, but the patient is fluid overload, so they need to be fluid restricted and perhaps diuresed. And that's why it's important to take a history and examine the patient and look at the patient's medications. When we talk about symptoms of hyponatremia, it really depends on the speed of onset, and these symptoms may be dramatic in the acute setting or very subtle. Acute symptoms may be associated with cerebral edema, so the patient may be initially weak, they may have headaches, there may be blurred vision, and then this gradually progresses to seizures and coma. So if the patient comes in having collapsed or having had seizures, a lot has happened and that patient is very vulnerable to a brain injury. Conversely, chronic hyponatremia may have happened very slowly over time. The patient may have been complaining of vague symptoms like fatigue and low energy, and that may well be the case for Matthew. They may have nausea, there may be cramps, headaches, delirium, or confusion. Let's look at another scenario. Rachel is 33 and she's collapsed at work. She has a prolonged seizure. Now, Rachel works as an executive in a medical technology firm with no medical problems or antecedent history. She's a CT of her brain when she comes into the ED. The CT demonstrates cerebral edema with no space-occupying lesion and no bleed. Her plasma sodium is 109 millimoles per litre. So Rachel has presented with life-threatening symptomatic hyponatremia. Let's treat the problem. Regardless of the volume status, symptomatic hyponatremia should be treated with hypertonic saline solution. That's 3% saline. The standard of care is to give 150 ml of 3% hypertonic saline over 20 minutes. And as I mentioned in the previous tutorial, the aim is to raise the plasma sodium by about 5 millimoles per litre and the osmolality by about 8. It is obviously variable depending on the patient's volume status and their size. If they get a 5 millimole increase, then we are happy, assuming that the symptoms are under control. And if the symptoms are under control, we can then give Rachel isotonic fluid therapy if necessary. If the 5 millimole target is not reached or the symptoms aren't controlled, then a second dose of 3% hypertonic saline is given and we go around and around and around until her symptoms are controlled. The general target is to raise the plasma sodium by less than 10 millimoles in the first day and then less than 8 millimoles subsequently. This is based not on evidence but on expert opinion. So we're looking at 18 millimoles in the first 48 hours. If you overshoot, you need to think about whether that's a problem or not, but that's the generalized goal. Now that we've gotten Rachel on a safer trajectory, the seizures have started to abate, she's beginning to wake up, it's now time for us to work the problem. As I mentioned in the previous tutorial, you need to do two sets of tests, blood tests and urine tests. We're going to do serum electrolytes, urea and glucose, and serum osmolality. We're also going to do urinary osmolality and urinary sodium. I will point out you should also do thyroid function tests and a random cortisol, but that's not really important right at this moment. Looking at Rachel's numbers, her sodium is 109, her potassium is 3.4, chloride 98, and creatinine 89 millimoles per litre. This is within normal range. Her glucose is 4 millimoles per litre and urea is 4 millimoles per litre, again within normal range, and her measured osmolality is 230 milliosmoles per kilogram. If you do the osmolarity calculation, you'll come up with more or less the same number. So this is hypotonic hyponatremia. In this setting, it's imperative we look at the urine. Let's look at her urine. Her urinary osmolality is 40 milliosmoles per kilo. And what that means is that Rachel is not concentrating her urine. Her urine is very watery. What else can we look at? We can look at her urinary sodium. And in this case, her urinary sodium is 12 millimoles per litre. That means that the amount of sodium in her urine is very, very low, so she's retaining sodium. So Rachel is not concentrating her urine, but she's retaining sodium, and her plasma sodium is very low. So let's work that problem. We have low sodium, low serum osmolality, so the extracellular fluid is dilute. We've looked at our antidiuretic hormone situation with her urinary osmolality, but her low osmolality means low antidiuretic hormone. In this setting, with a low urinary sodium, we can be very confident that the problem here is water overload. Once Rachel wakes up enough to take a history from her, it turns out that Rachel drinks 6 litres of water a day as part of her exercise regime, and she is completely water overloaded. So, how do we know how much water overload is present? Well, there's a great calculation for this. To estimate how much water overload exists, you use the following calculation. You look at percentage of body water times 1 minus the sodium divided by the normal sodium, which is 140. Now, male's body water is about 60%, so that number is 0.6. Rachel is a female, so her percentage body water is lower. It's 55% or 0.55, and she has a plasma sodium of 109. So let's just work this problem. The water excess is 0.55 times 60 times, that's her weight, times 1 minus 109 divided by 140. And you can work that out yourself by pausing this now. The result is 6.6 litres. And that's how much water Rachel needs to diurese off to bring her sodium back to normal. Recall Maureen. Maureen is another patient you got called to in the emergency room. She was seizing and her venous blood gas showed a sodium of 120 millimoles per litre. Maureen is 56. She works as a receptionist in a dentist surgery. She's overweight, body mass index of 34. She's hypertensive and she's treated with beta blockers and a thiazide diuretic. She was recently started on metformin for early type 2 diabetes and had a hysterectomy 3 years ago for postmenopausal bleeding. Again, Maureen has presented with symptomatic hyponatremia. Let's work the problem. We'll do her blood tests and her urine tests. On her bloods, her sodium is 120, her potassium is 3.6, her chloride is 98, and her creatinine is 95. Again, that creatinine is normal. Her glucose is 6 millimoles per litre, that's normal, but her urea is slightly raised. Her urea is 14 millimoles per litre. Her measured osmolality is 265 milliosmoles per kilo. So Maureen has hypotonic hyponatremia. When you see this, you must have a look at her urine. Maureen's urinary osmolality is 110 milliosmoles per kilo. So Maureen is concentrating her urine. Her urinary sodium is 35 millimoles per litre. So Maureen is losing rather than retaining sodium in the setting of a low plasma sodium. Now let's look at the decision tree. There's low sodium in the plasma and low serum osmolality, so we call this hypotonic hyponatremia. First question is antidiuretic hormone active? And if the urinary osmolality is greater than 100 milliosmoles per kilogram, there is high antidiuretic hormone activity going on. So we know that the hypothalamo-pituitary axis is working. The next question is, are the kidneys working? You look at the urinary sodium, and the urinary sodium is greater than 30 millimoles per litre. That means the kidneys are off, and there are only two reasons for this. The first one is the patient is getting diuretics, or the second one is the patient has acute kidney injury or a nephropathy. In this case, Maureen's urea is relatively high, but her creatinine is normal. This is indicative of dehydration, and the diagnosis is thiazide-induced hypotonic hypovolemic hyponatremia. So we're going to treat her with hypertonic saline and then follow her up with an isotonic saline solution. The next case is Sean, who's 29, and he collapses in the street, and he's brought into the emergency department, and his GCS is 5. He has a CT brain because everyone thinks he's had maybe a stroke, but it's normal. His plasma sodium is 112 millimoles per litre. So this is symptomatic hyponatremia. Sodium is 112. His potassium is 4.4, chloride 102, creatinine 94, glucose 4, urea 8. All of these are normal except for the sodium. The serum osmolality measured is 290 milliosmoles per kilo. So this is isotonic hyponatremia. Now we must calculate our osmolarity, which is with millimoles per litre, twice the sodium plus the potassium plus the urea plus the glucose. So it's twice 112 plus 4.4 plus 4 plus 8. And that works out, rounded up, at 245 milliosmoles per litre. The osmol gap then is the difference between the osmolality and the osmolarity, and that works out at 45 milliosmoles per kilo. There is something else in Sean's blood that is having an osmotic effect. And it turns out that Sean is intoxicated. A toxicology screen is sent and his ethanol level in his blood is extremely high. So Sean is drunk. In this situation, you need to make a decision. Is Sean a chronic alcoholic who has chronically low sodium, whose brain may be affected? Then you need to be extremely careful how you manage him subsequently. If this is a young guy who's just gone out in a binge, I think there's a terrible tendency to over-medicalize this. This is actually quite a common phenomenon. You may have incurred something similar, probably not as extreme as this yourself. And I think the best thing to do with someone like this with acute intoxication with a drug that is metabolized by the body is to actually leave him alone and sleep it off. Because underneath all of this alcohol, his body sodium is normal and his plasma osmolality is normal. And his brain scan shows no cerebral edema. So there's no evidence that he's had a osmotic anomaly to his brain. And once he metabolizes the alcohol and diureses out the water, then his sodium will normalize, and it may normalize quite quickly, but his sodium in his brain and in his blood were relatively normal to start with, and he won't have any massive fluid shift going from his brain. I will make a proviso on this though, that if the problem here was isopropyl alcohol or ethylene glycol, there are other things you need to consider. There's specific drugs that you use for ethylene glycol, and you might consider dialysis, but not for ethanol. Let's look at another scenario. Frank collapses in the street. His sodium is 150 millimoles per litre. Frank is 52, and he's very well known to the ED physicians and nurses because he has a history of chronic alcohol disease and alcohol abuse, and he was previously admitted with bleeding esophageal varices. Frank presents with what we presume is symptomatic hyponatremia, but let's work the problem. His sodium is 115, his potassium is 3.8, chloride is 90, and his creatinine is 80. That chloride is low for various reasons, but this is mostly a dilutional effect, but it could be from chronic hypercarbia if he's a heavy smoker as well. His glucose is 5 and his urea is 8, so these are reasonably normal, and his measured osmolality is 253 milliosmoles per kilo, so there is no osmol gap. This is hypotonic hyponatremia. Let's have a peep at his urine. His urinary osmolality is 130 milliosmoles per kilogram, so Frank is concentrating his urine. His urinary sodium is 20 millimoles per litre, so Frank is retaining sodium. So let's look at the decision tree. Hypotonic hyponatremia, ADH is definitely active because his urinary osmolality is more than 100. His kidneys are working because his sodium is less than 30. The next question you must ask is Frank edematous? And Frank is edematous, so it is likely that his hyponatremia is being caused by cirrhosis. He is likely fluid overloaded and chronically hyponatremic. Yes, he needs to be treated with hypertonic saline, but you need to be very careful about it, giving him volume, and be very careful about his entire management from this time forward. I would consider Frank to be at extremely high risk for developing osmotic demyelination syndrome or central pontine myelinolysis, about which I will discuss in a later tutorial. Grace is found collapsed at home and she's brought into the emergency room, and her plasma sodium is 118 millimoles per litre. Grace is also well known to the hospital. She is 68 and she had a recent small bowel resection with stoma formation. Initially post-op, there were very high stoma losses requiring IV fluids, electrolyte replacements, codeine, octreotide, etc. That all settled down and she was discharged last week. So Grace has presented with symptomatic hyponatremia. Let's work the problem. The sodium is 118, potassium 3.1, chloride 90, magnesium 0.5, and creatinine 150. Her glucose is 8 millimoles per litre and her urea is 20 millimoles per litre, and her measured osmolality is 272 milliosmoles per kilogram. That is close to normal despite that really low sodium, but this is still hypotonic hyponatremia. What's driving up that osmolality is the high glucose and the high urea. We need to look at her urine. Her urinary osmolality is really high. It's 200 milliosmoles per kilogram. So she is really concentrating her urine. She's working very hard to retain fluid. Her urinary sodium is extremely low. So she's really trying hard also to retain sodium. So let's look at the decision tree. We have hypotonic hyponatremia. No question, antidiuretic hormone is active. The kidneys are definitely working because her sodium is so low. Maureen is not edematous, but her urea is very high. So this is a case of hypovolemic hyponatremia. In this situation, it's being caused by persistently high stomal losses. You can give Grace some hypertonic saline, but she will need a fairly rigorous fluid resuscitation, preferably with balanced solutions. In this case, lactated ringers will be a good choice because of its relatively low sodium content and its modest osmolality. You're going to have to chase the magnesium, calcium, potassium, phosphorus, etc. And don't forget she's at risk of refeeding syndrome. Let's review this tutorial. In this tutorial, I discussed hyponatremia and body volume status. I discussed the treatment for acute symptomatic hyponatremia. I discussed working the hyponatremic problem and a scenario in which you might choose not to treat acute hyponatremia. In the next tutorial, I'm going to look at two other causes of hyponatremia. One that is quite tricky to deal with, where there's quite a lot of controversy in the management, and that's the syndrome of inappropriate antidiuresis. I will also mention cerebral salt wasting. I'll see you then, and I guarantee you'll learn something. So that was part 2 of hyponatremia. If you're finding these tutorials useful, don't forget to follow me at ccmtutorials.org and subscribe at YouTube. I'll see you next time.